Imagine a scenario where millions of patients are denied life-saving healthcare. And the crazy part? It wasn't a prejudiced doctor making the call. It was a line of code. Welcome to This Explainer. Today, we're diving straight into a pretty chilling reality in modern medicine. We usually think of algorithms as cold, calculating, and, well, totally objective, right? We trust them to map our commutes, sort our emails, and now, increasingly, to dictate life and death healthcare decisions. But what actually happens when the code we rely on to be neutral is trained on a deeply flawed, historically biased dataset? Well, looking at the source material today, we are unpacking a massive structural crisis in health tech. We're going to see exactly how historical disparities are literally being hard-coded into the software that manages millions of human lives. To really grasp the massive scale of this, we just have to look at this absolute bombshell of a study from 2019. It was published in the journal Science by researchers Ziad Obermeyer and his team. They took a hard look at a widely used commercial healthcare algorithm. And I mean widely used. This thing was responsible for managing the health profiles of millions of patients across the US. Now, the algorithm's job was actually pretty simple. Predict which patients were going to get the sickest so that hospitals could step in early with life-saving interventions and extra care. Sounds great, right? But the researchers uncovered this massive, automated blind spot. They found that if this algorithm had been calibrated to look at actual medical need instead of the flawed metric it was actually using, well, exactly twice as many Black patients would have been flagged for these critical interventions. Just think about that for a second. The number of Black patients getting the extra care they needed was cut by more than half. 2 times as many people should have gotten help.
So, let's look at the core flaw here, and specifically how cost is used as a proxy.
To understand how on earth this happened, we really have to break down the mechanics. How does an algorithm designed to help millions accidentally automate systemic inequality? Well, here's the thing. The developers of this algorithm absolutely did not set out to build a racist machine. Actually, it was designed to be intentionally colorblind. They explicitly excluded race as a variable. So, how did it still produce such a drastically biased outcome? The scandal, which is often referred to as the Optim algorithm scandal, detailed by Obermeyer's team and analyzed by scholars like Ruha Benjamin, really exposes this core flaw in the data. It's all about the proxy variable. See, to train an AI to find sick patients, you have to give it a measurable data point. You can't just say, find sick people. So the developers chose healthcare spending. They essentially told the AI, mathematically speaking, that a patient who costs the hospital a lot of money is a sick patient, and someone who costs very little is a healthy patient. But, and this is a massive but, here is the reality of the US healthcare system. Historically and persistently, society just spends significantly less money on Black patients than on white patients with the exact same level of medical need. We're talking barriers to access, lack of insurance, unequal treatment. All of this means Black patients generate fewer costs on paper. So the AI looked at that historical data and just did the math. It assumed that because Black patients were generating lower costs, they must just be healthier than equally sick white patients. It literally equated a historical lack of financial investment with a lack of biological illness. And honestly, this brilliantly illustrates the heart of the whole issue. Princeton researcher Ruha Benjamin captured it perfectly. She wrote, "If individuals and institutions valued Black people more, they would not cost less, and thus this tool might work similarly for all." It's such a powerful point, right? The algorithm actually isn't broken. It's doing exactly what it was programmed to do. It perfectly, flawlessly reflects a broken society by identifying patterns in historical data and projecting them right into the future. This really proves that the labels we put on data matter deeply. When developers use cost as a synonym for care, they are basically baking historical disenfranchisement directly into the mathematical architecture of our future.
Which brings us to our next point. Let's talk about digital triage. And imagine Henrietta Lacks in 1951. To truly grasp the real-world stakes here, to get past these abstract regression coefficients, we really need to ground these numbers in human lives. So we're going to apply this modern algorithmic logic to a historical hypothetical laid out by Ruha Benjamin. Let's look at one of the most famous figures in medical history, Henrietta Lacks. Imagine it's the year 1951. Henrietta Lacks, an African-American mother of 5, presents to Johns Hopkins Hospital with severe pain, bleeding, and a knot in her stomach. Now, historically, we know she was admitted to the segregated Negro wing of the hospital under the legal discrimination of Jim Crow. But in our thought experiment, let's say she's evaluated not by the prejudice laws of the 1950s, but by this state-of-the-art colored blind predictive algorithm from 2019. She undergoes what we call digital triage. Because this modern tool assesses risk using the predicted cost of care, and because the system historically spends far less on Black patients, the automated system looks at her profile and drastically underestimates the level of attention she actually needs. Based on this supposedly objective mathematical result, she's discharged. And without care, her condition rapidly deteriorates. The outcome is exactly the same as it was under overt segregation. Why? Because the historical underfunding of her demographic is baked right into the code making the decision. So the really crucial realization here is that this is not just a math error. It's a manifestation of what Ruha Benjamin terms the new Jim Code. She defines this as automated systems that hide, speed up, and deepen racial discrimination, all behind this shiny veneer of technical neutrality. Think about it. When a human doctor denies care based on race, we can identify that bias, we can challenge it. But when a proprietary algorithm denies care based on millions of data points hidden inside a black box, it's entirely shielded by the illusion of mathematical objectivity. The bias is effectively laundered through the technology, which makes it infinitely harder to detect, let alone fight. And this issue is absolutely everywhere. Let's look at what's hidden in plain sight: clinical race corrections. You see, this systemic flaw extends way beyond just one commercial predictive algorithm managing hospital resources. It's actually built into the entire medical field. When we look at specific, everyday diagnostic tools, the ones doctors use right now to make immediate medical decisions, we find that they arbitrarily adjust scores based on a patient's race. These are called race corrections, and they were detailed in this staggering piece of research by Dr. Darshali Vyas and her colleagues. The research shows how these corrections consistently steer life-saving resources away from minority patients. For example, look at the American Heart Association's heart failure risk score. It literally adds 3 points to your estimated probability of death if you are categorized as non-Black. The result? Clinicians might direct more intensive cardiology resources toward white patients and away from Black patients. Or take a look at nephrology, the algorithms that estimate kidney function, known as the EGFR. They use a multiplier if the patient is identified as Black. This multiplier artificially reports better kidney function for Black patients. What does that actually mean? It means their disease has to progress much further and become much worse before they're finally referred for specialist care or put on a kidney transplant list. Diving straight into the actual tables from the actual medical literature here, this is from the New England Journal of Medicine. You can see exactly how Black is treated as this rigid clinical input variable. It actively alters the estimated risk for heart failure, kidney disease, obstetrics, oncology, the list goes on. And arguably, the most shocking part noted by the researchers, often there is absolutely no robust biological rationale provided for these adjustments. None. Take that EGFR kidney adjustment, for example. It was historically justified by this outdated, entirely unproven notion that Black people on average have more muscle mass and therefore release more creatinine into their blood. It's basically an empirical observation of a health disparity that got translated into a rigid mathematical rule, all without ever proving an actual genetic cause. Researchers are practically shouting from the rooftops that treating race as an immutable biological fact in these equations is absurdly reductionist, because as we know, race is a social and political construct. It is not a genetic or biological mechanism. By hard-coding race into clinical algorithms, we are completely confusing the biological effects of racism with biological race itself. It is the experience of being Black in a marginalized society. The environmental stressors, the socioeconomic barriers, the unequal treatment, that is what impacts physiological health. It's not some inherent genetic difference that maps perfectly onto a social category. When we let algorithms blindly adjust for race, we're blinding ourselves to the actual structural injustices that cause these health disparities in the first place. We just cement them as permanent mathematical facts. So where do we go from here? Let's move into our final section, accountability and the human warranty. Knowing how deeply embedded this issue is, how on earth do we fix it? How do we untangle decades, even centuries of historical bias from the absolute cutting edge of artificial intelligence? Well, we have to shift from just diagnosing the failure to actually exploring structural solutions. Specifically, looking at the World Health Organization and their human warranty framework. If you look at this incredibly complex web of the modern health data ecosystem, you can see data pouring in from everywhere. Clinical records, insurance claims, public health surveillance, smartwatches, genomic biobanks. It perfectly illustrates exactly how easily bias can infect AI training data. Think about it.
If any single sector in this entire circle historically underserved a population, the data it generates is going to be biased. And because AI models learn by recognizing patterns in these massive datasets, they will naturally bias toward the majority dataset, which inevitably disadvantages marginalized groups. This makes what experts call ethics by design an absolute necessity for every single stakeholder on this map. You simply cannot build a fast algorithm and try to patch the ethics in later. It doesn't work. To combat this whole mess, the WHO has outlined some core AI ethics principles: avoiding harm, promoting well-being, ensuring strict fairness and non-discrimination, and respecting human autonomy. But what does that mean when it's practically applied to code? It means action. Developers can no longer hide behind the excuse that their algorithm is, just doing the math. They have an active, ethical duty to identify and mitigate biases right from the very start. If a racial or ethnic minority is underrepresented in a historical dataset, developers must proactively oversample that group to ensure the AI achieves an equal quality of care. They have to rigorously audit for contextual bias before a tool is ever even allowed to be deployed in a hospital. Ultimately, resolving this requires a massive paradigm shift in how we view healthcare technology as a whole. We've got to shift our focus away from using algorithms merely to police and triage individual patient bodies. Instead, we should use all this incredible analytical power to audit the institutions themselves. We need to evaluate the powerful entities, the hospitals, the mega insurance companies, the tech developers that are producing and profiting from these racially biased AI models. We absolutely have to design systems that hold these structures accountable for the risk they create, rather than just building tech that optimizes how efficiently they can manage the damage. As we wrap up this explainer, I really want to leave you with a profound provocation, something I definitely want you to discuss and debate in the comments below. If an AI perfectly follows historical healthcare data and as a result systematically denies marginalized people life-saving care, is that code actually broken? Or is it working exactly, flawlessly, as our history designed it to? And when these automated systems inevitably scale up historical harm to millions of patients, where does the legal and moral guilt lie? Who goes on trial when the algorithm discriminates? Is it the programmer, the hospital, or the society that generated the data in the first place? Let me know what you think down below, and thank you so much for engaging with this crucial explainer.